Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Hello, welcome to today's presentation presented by Dr. Bryant Bonner, orthopedic surgeon with Washington Hospital's Institute for Joint Restoration and Research. Dr. Bonner was born and raised in Sacramento before heading to Boston for college. He received his undergraduate degree from Harvard University and his medical degree from Harvard Medical School. Dr. Bonner completed his orthopedic surgery residency at the Harvard Combined Orthopedic Residency Program. And now, please welcome Dr. Bonner.
Hi, my name is Dr. Bryant Bonner, and I'm a board-certified hip and knee specialist at SAW Orthopedic Associates, and today we're going to chat about advances in joint replacement for younger and more active patients. Briefly, just a little bit about me. I was born and raised not too far from here in Sacramento. I went back east thinking it was going to be a short stint for college, but ended up staying there for almost 15 years, completing my college, my medical school, and my orthopedic residency training all at Harvard. I then completed a fellowship in adult reconstruction and joint replacement in Salt Lake City, Utah, and then returned back to California to SAW Orthopedic Associates shortly after that. Some of the procedures that we perform include total knee replacement, partial knee replacements, total hip replacements, as well as revision hip and knee replacement surgeries. We have specialties in multimodal pain management, minimally invasive surgeries, as well as rapid recovery techniques, outpatient joint replacement, and specifically anterior hip replacements and robotic-assisted total knee replacements. There's going to be a lot of information thrown at you today, and certainly if you want some more time to delve into it and research the topics we talk about, you can find our website here, as well as the phone number for our office as well. And then you can always shoot me an email directly. My email address is there, which goes straight to my phone, and I'm happy to chat with any questions you might have. So a brief overview of what we're going to talk about today, including a brief overview of arthritis, the basic treatment pathway, joint replacement surgery as a whole, and then some of the specific advances that are unique to younger and more active patients. So what is arthritis? Osteoarthritis is by far the most common cause of chronic joint pain. There's a number of different flavors of arthritis, which include things like inflammatory conditions like rheumatoid and lupus, but by far and away the most common is osteoarthritis, which is general wear and tear over time, the loss of cartilage from the smooth joint surfaces that glide against each other. Arthritis usually progresses in a stepwise fashion, so starting from the left and moving all the way to the right. You can start to have some minimal disruptions in the cartilage, which are these white end caps to the bones on this diagram here. So this is your femur or thigh bone, tibia or shin bone. As mentioned, the white represents your cartilage. So you can start with these small little defects that are pretty microscopic. But as time progresses, you can see those cracks start to progress and become more widespread on both the femur and tibia, and become deeper and more widespread as time goes on until you have full thickness cartilage loss like you can see here. The ends of the bones are now exposed, you're bone on bone, which can be especially painful and debilitating. There's a number of different causes of osteoarthritis. As mentioned, the most common tends to be age, wear and tear over time. In general, it seems to affect women more than men. There does seem to be a genetic component, so certainly if your parents, grandparents, siblings have arthritis, there may be a chance that you too may have a higher chance of having arthritis. And then of course any excess weight that you might be carrying allows for increased stress across your joints. So we like to mention for every additional pound that you're carrying, that's 4 pounds across your hip or knee joints that they experience. Some of the most common symptoms of arthritis include things like pain, swelling. You can start to develop stiffness in and around the joint, and especially with knees, you might notice that you become a little bit more knock-kneed or bow-legged as time progresses. Arthritis is one thing that's certainly not going away and is only going to become more and more prominent as our population grows and ages over time, and you can see that trajectory is only spiking upwards. One reason that arthritis, in particular osteoarthritis, which is OA here on the slide, is more prevalent is in addition to just patients getting older, so you have an increased wear and tear over time, we're also carrying a little bit more weight. And as mentioned, every additional pound is 4 pounds additional that your joints experience from your day-to-day activity. In addition, it seems like folks with diabetes also have a higher likelihood of being diagnosed with arthritis over time. And in the past, people might just say, I won't run or I won't do my active things just because I have bad knees. But now, as time has gone on, patients are less and less willing to accept the limitations that arthritis is giving. And because of that, we're starting to see more and more young patients in our office with arthritis and in need of a joint replacement. So these numbers are only between 2000 and 2017. And you can see the age range is from 45 to 64. There has been a huge increase in the number of patients who are getting hip replacements, a 211% increase in hip replacements, and then a 240% increase in patients who are undergoing knee replacements in that age group. There was an increase in patients beyond age 64 and beyond, but not nearly as significant as this here. And what's important to note here is that these big jumps in the hip and knee replacements are what we consider inpatient joint replacements, so they're often in the hospital for multiple days. That does not include outpatient joint replacements, which is becoming a fast-growing topic that we're going to talk about briefly at the end of this chat as well. And more patients are getting their surgeries on an outpatient level, so these numbers must be much, much higher. The way we diagnose x-rays tends to be a clinical diagnosis. So when we see in the office, we'll do a physical exam, we'll take x-rays, and we'll take your history. That's by far and away the most common way that we'll diagnose arthritis and chat about your potential treatments. We always like to start with non-operative treatments to begin with. So things like physical therapy, exercise, things to help increase with joint mobility and strengthening, as well as maintain and increase your range of motion around your joints. There are some other things like acupuncture. Sometimes some supplements can help provide some relief. Once those are exhausted, then we start turning to things like medications, injections, or weight loss. Medications include things like Tylenol, anti-inflammatories such as ibuprofen, Motrin, Aleve, all of which can help with pain, inflammation, and swelling. You can also try topical pain medications, things like the Voltaren creams or gels, which can also help. In addition to those, we can try some injections into the knees that we'll talk about on the next slide, cortisone and hyaluronic acid, which is known as the gel or lubricant injections. And then as mentioned, the weight loss, as we talk over and over again, every pound that you lose is an additional pound off of those joints, or a multiplying effect across those joints. So the two types of injections that we most commonly discuss in the office are steroid injections as well as the hyaluronic acid injections. So at the top you can see we mentioned the hyaluronic acid injections. These are the lubricant, the gel injections. These are supposed to help supplement the joint fluid in your knees to help provide some conditioning, some cushioning and lubrication in the knee. But by far and away, the most common still is the steroid injections, which are helpful for pain, inflammation, and swelling, especially delivered locally in the knee, and what most folks get as a first line here. Once those have been exhausted, then we start talking about things like surgery. And it's important to note that the non-operative treatments that we just discussed are to manage symptoms. They're not going to change, stop, slow down, or reverse the arthritis that you already have. They're to help manage the pain, swelling, and any other symptoms that you might have. Surgery is designed as a way to address the underlying issue from the get-go. So first we'll talk about knee replacement surgery. Partial knee replacement is one of the things that we specialize in and that we offer. This is indicated in certain circumstances where you have arthritis in only one compartment or one area of the joint. And so as you can see here on this diagram, you have your femur or thigh bone, your tibia or shin bone. The metal is the shiny bits here on the femur and the tibia and that piece of plastic here. So it's just this one area of the knee. The rest of this is left alone, so you have your own cartilage and meniscus. And it's a great surgery in the right patients, and certainly one that we are very selective in doing, just because we got to make sure that arthritis is isolated to just one area of the knee. And to recap how the knee works, you have your femur or thigh bone here, your tibia or shin bone here, and your patella there. Your side stabilizers are here, so this is your LCL and your MCL over there, and your cartilage is on the end caps of both of those. You can see here on the left you have a healthy knee with that nice smooth cartilage, and on the right a very clearly diseased and arthritic knee where that cartilage is worn and torn and has seen better days. As mentioned, there's a couple of different flavors of knee replacement. So partial knee replacement, which we talked about, and we're going to talk about total knee replacement, which resurfaces the entire joint bearing surfaces of the knee. And then of course there's complex or revision knees that we won't talk about today. So the way it works in this video here, you can see again, you have your femur or thigh bone, your tibia or shin bone, and your kneecap here in the front. We're just going to go through a quick animation. What I talk about when we're discussing knee replacements is I think it actually needs a rebrand because it's more of a resurfacing than an actual replacement. And the way it works is we shave 9 to 10 millimeters off of the end caps of your bones and then put a new cap on the end, which you'll see here, like a cap on a tooth. So you see that knee joint working well there. And these are the components that you use. You can see a new cap on the femur, a new cap on the tibia, and that piece of plastic in between, which replaces those damaged meniscus. So you can see we shaved that 9 to 10 millimeters off of the end cap of the femur, a new cap there. Same with the tibia, and then that piece of plastic in between. We'd also do that on the back side of the patella or kneecap as well, and there you go. It's about an hour or less, and afterwards you can put full weight on that leg right away. And next we're going to transition to hip replacement surgery. And so just a brief overview of how the hip works. The hip is more of a ball and socket joint. So you have your pelvis here on the right side. If I can get my cursor somewhere. There we go. Here's your pelvis, and you can see the ball here resting in the socket. And that's at the top part of your femur or thigh. And you can see again on the left is a nice healthy hip. The pink in this diagram represents the nice smooth cartilage. And you can see over here on the right that diseased hip, that cartilage has seen better days and is full of bone spurs and is grinding away. And the way a hip replacement works is we remove that damaged ball completely and we clean up the damaged socket side, and then we put in a new socket, a plastic liner, a new ball, and a stem that goes down your femur or thigh bone. Again, it's about an hour or less, and you can put full weight on this leg right away. And so what are some of the advances in joint replacement specifically for younger and more active patients? One of the biggest things that have come around in the past 5 to 10 years have been the improvement in our plastic liners. So as you saw on the last slide, there's a plastic liner between the ball and socket of the hip joint and then between the implants on the femur and thigh bone. That used to be our weak spot, and so that could wear a little more quickly and cause issues or need a replacement sooner rather than later. The way that's manufactured has changed, and so implants are lasting longer and seeing less and less wear. The biggest gains have been in hips, but certainly in knees, it's been a huge, huge game changer. So we're not seeing nearly the same issues that we used to see with the plastic, which could lead to surrounding inflammation, issues with the implant becoming loose, pain, instability. So that's been our biggest advancement in our joint replacement. So because of that, our implants are lasting longer. So traditionally we said that implants would last 15 to 20 years would be good. Now we're saying 20, 25, 30 plus years because of that. In addition, some of our implant technology has changed. In our hips, we do what we call press fit implants. So you wedge the implant in tight and it requires bone to grow into that, so it only becomes stronger over time. That is how our hips are traditionally done. Knees are starting to see the same sort of technology. So on the underside of this implant here, you can see this zoomed in view of the surface that's designed for bone to grow into it, so that over time, the implants will only go stronger as bone grows into it. In addition, we become much more efficient and slick with how our procedures are done. So as mentioned, both hip and knee replacements are about an hour or less. In addition, we'll talk a little bit about robotics here in the next couple slides, which have helped not only to provide more accurate and precise cuts, but allowed for patients to have increased mobility and less pain afterwards as well. And overall, we'll talk about advances in surgical approaches, such as the anterior hip approach, which we'll talk about, physical therapy, anesthesia, and pain control, all of which have helped lead to shorter patient recovery times and allowed more patients to go home the same day of surgery, the outpatient surgeries, which we'll talk about at the end here. So specifically chatting about robotic-assisted surgery, you can see this here with a robotic arm and a planning screen here. Robotics is not necessarily a new procedure. The first documented robotic procedure was in 1985, being a neurosurgical biopsy. The first orthopedic robot was used in 1992, and it was actually developed by a company here in Fremont, and since then has only continued to explode and become more and more popular. So, as mentioned, a robotic-assisted knee replacement helps to get a precise knee implant fit and balance of your knee that's unique for you. So you can see here the patient knee is outlined here in blue. There we go. So this is the shin or calf, and this is the femur or thigh bone area. There are trackers in both the femur and the tibia, and same on this robotic arm. What we'll do is we'll make a 3D model of your knee using anatomic landmarks during the time of the surgery. And you can see them on this screen here. Once we have a model of your range of motion and the balance of your knee, we can then plan, are we going to take a little bit less, a little bit more bone, are we going to rotate the component this way or that way, what happens if we change the thickness of the plastic, all of which to get you an optimal knee specific to you. The robotic arm will then swing into view once we've finalized our plan and help us make those cuts down to 1/4 to 1/2 of a millimeter of precision and accuracy, time and time again. And it's really helped to provide more predictable and reproducible results again and again to get that knee in the exact balance and range of motion as we want it for every patient, and is especially useful for folks who have maybe some trauma, injury, or deformity that may provide a little extra assistance in getting that knee as perfect as we can be. In addition to robotic-assisted knee replacements, there are other things that have been coming out, including patient-specific instrumentation as well as implants. So these typically are CT-based, so patients can get a CT, and then because of that, we can then form a custom one-use cutting guide, so you can see them here for the femur, and then one for the tibia, to provide specific cuts, and then they can also sometimes make some 3D printed implants that are unique for you as well. Because of that, we can sort of streamline the operating room time because we're not necessarily having to take measurements because we already know that based on your CT. And again, can be especially useful for folks who have some abnormal anatomy, fractures, trauma, existing hardware, and the like. And now turning our attention to hips and some of the advancements in our hip replacement surgery, the direct anterior approach has been one of the biggest game changers and has exploded in popularity and use throughout the country. And so what it basically is just a different way, different surgical approach that we get down to the hip and are put in our implants. So traditionally the incision has been on the side or the back of the hip, but this one is on the front. And because of that, it is a muscle-sparing approach. We work through a unique muscle plane, and because of that, we can then also use X-ray throughout, because you're flat on your back, to confirm implant placement, leg length accuracy, and really get that leg dialed in perfect over and over again. And as mentioned, there's a million different ways to get down to the hip. Traditionally, the posterior hip has been the most popular. See if it's this dotted blue line on this. This is a side view of the hip. So the buttocks is on the left and the front of your abdomen is on the right. So that dotted blue line is the traditional approach, and the purple line near the front is here. That's the anterior approach. So it doesn't seem like it's much of a difference between those two approaches, but it makes a world of difference. Just those few millimeters can allow for faster recovery, less pain, and less muscle disruption afterwards. Here is a cross-sectional view. So the patient is flat on their back. So this is your buttocks, and then this is the front of your abdomen. You can see the ball here and the socket there. The anterior approach is this purple line here. You can see it goes between a natural muscle plane, and there's no muscle cutting. We go straight down to the hip joint there. Whereas the posterior approach, you may have to disrupt some of that gluteus and then take off some of those external rotators. Overall, they do very, very well, equally long term, but at least in the beginning, the recovery can be much faster and less painful with the anterior hip approach. In addition, as mentioned, we can use X-rays throughout the procedure with an anterior hip, And you can see us working here with the X-ray coming into view, which allows us to get an idea of where we're putting our implants in space and confirm, give us a double check that they are exactly where we want them to be. But we have the added benefit of having an additional AI assist technology that's been especially useful in the operating room and provides us an additional double check and confirmation that we're putting it where we think we are. So this is a pre-surgical X-ray in the operating room, which gives us an idea of where the leg lengths are in comparison to each other, what we call the offset, so we can talk about the hip center. And then once you have a cup in place, it'll confirm what your inclination is as well as your version, so we can get that right in the same spot every time to help optimize those mechanics. And then you can see here, we have some trials in, and so we're looking at different leg lengths as well as offset so that we can maximize this to match the other side. So you can see it looks like they're a little bit short, so we'll change some things to get that leg length matched to the other side and confirm things at the end. So that's been a huge, huge game changer and allows for a very streamlined and smooth process as well as we do these anterior hips. While these advances in joint replacement have certainly been beneficial to help minimize recovery time and speed up our healing, you know, we do still express caution for our younger patients in avoiding high impact activity, things like running, basketball, racquetball, skiing moguls, just because it can put extra pressure and stress on the implant. As mentioned, the biggest advances have been in our plastic technology and the amount of stress that it can take, and the wear that it experiences over time is much less. But still, we like to maximize the life of that implant, and certainly with younger patients, we do express some caution if you're going to do a lot of running, jumping activities. And we do still caution very young patients, you know, while we do say that the implants are lasting longer, 20, 25, 30 plus years, there's still a likelihood, because it has only been 25-ish years since the change in that plastic, that you may require a future procedure in the future to change out that plastic liner, to put new tires on, so to speak. And so, in addition to those advances in the surgical approaches and technology, we're especially proud of our program here at Washington Hospital and joint replacement to help ease the recovery and speed up the healing process for our patients as well. All of our patients get a pre-op education, so it's an online class now that will provide a good overview of what to expect before, during, and after your stay here, and is led by our PT and OT folks here. It is especially beneficial and useful as you prepare for a replacement. In addition, all of our patients get a detailed binder that has anything and everything that you could want to know about your hip or knee replacement, and should answer most, if not all, of your questions about the surgery, both before and after. In addition to the folks that we have working at the IJR, this is a picture of Dr. Saw and myself. We're fellowship trained surgeons. Our anesthesiologists are dedicated to us, the OR joint team, as well as the surgical techs and nurses in the OR, as well as the nurses in the joint replacement unit, specialize in our joint replacement patients and are very familiar with our recovery and physical therapy protocols. And this is all that we do. So our colleagues joke that we do 4 surgeries: left hip, left knee, right knee, but we get very good at those 4 surgeries. And you know, Fremont is a very small town down here, but our catchment area is very large, and patients come from all over Northern California to come see us because we're good at what we do. You don't have to take my word for it. You can see we've received a number of different accolades for it. You know, our health grade score is 5 stars in both hip and knee replacements since 2002, consistently ranked in the top 5% of the nation. And then as regards to joint replacement here in California, we're currently the #1 joint replacement center. Here's just some more accolades looking at consumer reports, looking at our hip and knee surgery rankings. Red on the score is better, and you can see compared to some hospitals in the area, we score very well. And one thing that we are especially proud of as well is our outpatient joint replacement, and this is especially useful For folks who are younger and more active as well, the ability for patients to get home the same day of surgery to help expedite their recovery and make it a more smooth and enjoyable experience. There's just been an evolving trend over time of a decreased length of stay, and it seems that patients are recovering very well and faster at home. And we actually began this program here at Washington in 2018, but it sort of accelerated just like everywhere in the country after the COVID pandemic in 2020. Some of the benefits of outpatient joint replacement include that it's a more comfortable healing environment, so you have your own bed, your own food, you have familiar people around you, you have more control of your medications, and you certainly get a better night's sleep than us constantly interrupting you overnight. What I hear all the time is it safe? Is it safe to go home the same day, only a few hours after surgery? And absolutely. Certainly there are things that we check boxes that we have to hit along the way, and so everybody and every part of the team has to be doing their part for a successful outpatient joint replacement. So you as a patient must be mobilizing well. We've got to make sure your pain is under control or in a reasonable spot, that you're not nauseous or vomiting or retaining any urine. We're going to make sure that you're medically stable, of course, and if you have any existing medical conditions, that they're well controlled and stable. And then finally, I think a very important and underrated piece is that you have a coach or support system. That can be a family, a friend, a colleague, somebody that can keep you on task, motivated, and of course check on you to see how you're doing. And so there are several keys that we have to check along the way for a successful outpatient joint replacement. And I think one of them is the first one is certainly belongs to us as the surgeon or surgical team, selecting the right patients. And obviously, younger, more active patients may be more predisposed to going home or doing an outpatient surgery, but age alone is not a contraindication. And so certainly healthy patients, regardless of age, who have no health issues, or of course mild systemic issues that are well controlled, can certainly do well and go home that same day without any issue. The type of anesthesia that we use has been a huge game changer as well. No more general for everybody. More often than not, it tends to be a spinal anesthetic, so you're numb from the waist down. Most folks get a little sedation and take a nice nap. Some folks who are braver than me, and I do this for a living, want to stay awake and watch their own surgery. As a result, folks can recover very quickly and get up and mobilize only within a few hours of surgery. In addition, we also give preoperative meds that can help reduce pain as well as nausea and vomiting to make sure that's well controlled after the surgery as well. In addition, as we talked about, our surgical techniques are huge, so we want to make sure that we're doing less invasive surgery so you have less pain, and then things like an anterior hip approach is muscle sparing, so that's less pain, improved mobility as well. The minimally invasive surgeries or surgical techniques also help to improve blood loss, and there are other things that we can use at the time of surgery, including things like tranexamic acid, certain coagulation devices at the time of surgery to help minimize that as well. And then in addition, because this is all we do, our surgery times tend to be quite short because we're very good at this and we're very streamlined in making sure that we're in and out and do things well. In addition, as mentioned, we specialize in multimodal pain control. We try to hit it at many different pathways along the way, and I'll show you on the next slide exactly what some of those are. And in addition, we'll do some special injections and topical solutions at the time of surgery to help as well. So you can see here, this is a whole pathway starting from the brain all the way down to the skin level or the superficial layer. So from the brain level, we're using things like opioids, Tylenol, anti-inflammatories. The spinal level, we're using things like the spinal anesthetic. Again, the opioids will help there as well. As we get more close to the skin and as the surgical site, we're using things like local anesthetics, anti-inflammatories that go inside the incision as well. All of that to hit it at multiple different pathways along the way to help minimize your pain and help expedite recovery. And then finally, having a good support system, as mentioned, is paramount, and that can be anybody that is helpful for you. They can help things like meal prep, medications, even just checking in to make sure things are going well and push you as you recover along the way. And so in summary, as mentioned, arthritis is the most common cause of chronic joint pain worldwide. Joint replacement, whether it's a hip or a knee, is definitive and an excellent treatment for arthritis. And then a lot of our advancements in joint replacement surgery, including things like technique, implants, the anesthesia, pain control, etc., have helped to improve postoperative outcomes and speed recovery that can allow return to an active lifestyle, especially for our younger, more active patients. Our goal is to get you out there sooner rather than later and be as active as you can for as long as you can. And together, all of these have allowed eligible joint replacement patients, young or old, to go home just hours after surgery safely. Thank you.
Thank you, Dr. Bonner. We have a couple of questions. The first one is, why do you think that you're seeing more young people in need of joint replacement?
I think well, one is the obesity, so we're starting to see folks who may be carrying a little bit more weight. But two, I think traditionally we have tried to push patients longer and longer to wait for joint replacement, given we were worried that implants may not last as long, and if you're more active, it may wear out faster. But I think now that our implants and technology have improved, so that implants are lasting longer. And then two, the quality of life that folks want is worth it to get this addressed quickly and help them return back to an active lifestyle sooner rather than later.
Okay, our next question is, you talked about the bone adhering to the device. How long does it take for that to happen?
Great question. So it's usually around 6 to 8 weeks is what we tell folks, but it's stable from day 0. So when we put it in, it's good to go right away, but it's only going to get stronger as bone grows into that implant. Typically, it's usually around 6 to 8 weeks, and you're good to go, and it will only get stronger from there, but from day 0, it's still good.
Dr. Bonner, our last question is, are all the joint replacements that you do you use robotics?
Not all surgeries that I do use robotics. Certainly with the hip replacement surgeries, it's not necessarily as useful just because we have the AI assist technology. We have X-ray throughout, all of which act as that sort of robotic assistance or technology. But certainly with knees, it's very, very useful, and the majority of my knees are still robotic assisted. But certainly this is a conversation we can have in the office. We can talk about the pros, the cons, the different types of robotic assistance that are available to optimize that solution that's best for you.
Okay, thank you, Dr. Bonner, for this insightful presentation. This does conclude our program. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our Facebook page and YouTube.